Hello and welcome to the CSN3M Mindset Monday podcast. I am Andrew Wade with Case Specific Nutrition. On this channel, we focus on the 3 M's: mindsets, myth busting, mentoring, all as they pertain to health and nutrition. This podcast is brought to you by Case Specific Meal Prep, our very own in-house, chef-inspired and dietitian-approved meal delivery service. Check us out at csmpgh.com. Order by Thursdays to get fresh delivered meals contactless to your door on Sunday to start your week right. Before we dig in today, please subscribe to our channel and share today's podcast as your favorite episode on social media. Help us spread the health by tagging a friend and loved one so they can benefit too. And please don't forget our hashtag, Spread the Health. For more case-specific nutrition content, you can follow us at Case Specific Nutrition on all social media, as well as casespecificnutrition.com and pittsburghdietitian.com. On today's episode, we are going to be discussing a lot of really exciting topics, but the main focus is really going to be that on preventive medicine, preventive care, as it pertains to health and wellness. You aren't going to be hearing as much from me today because I have someone who is a fantastic interviewee, Dr. Eric Scavarla with Epic Medicine. Eric, thank you for coming on. I really appreciate it.
I appreciate having me. I was looking forward to this all week.
Good. That's what I like to hear. And again, basically what we're going to do is Eric and I are going to have a fun conversation today. I'm going to first let him tell us a little bit about him and his background and what he does and what Epic does and all of those good things. But then from there, we're going to dig into some really exciting topics in the world of preventive care. This is going to discuss sort of that dichotomy that currently exists relating to the sort of either medicine first or avoid medicine at all costs, and recognizing that just like in everything in our society, we tend to hear these polarizing extremes and the truth lies somewhere in the middle. And so we're going to investigate that middle. We're going to embrace that gray area. And as a dietitian, as the owner of a preventive nutrition practice, someone that doesn't prescribe meds, right? I'm not able to prescribe medication. I'm going to be able to provide the insights in that realm. And I think as you get to know Eric, you're going to get to hear some really exciting things coming from a doctor and how he perceives things and why he does what he does and why our businesses have so much overlap and work together and collaborate in such an exciting way to try and really create outcomes that are positive for the individual now and later. So without further ado, Eric, why don't you just start with a little background about you? We'll dig into the business in a bit, but why don't you just tell everybody sort of your professional background and, some of your sort of underlying philosophies and what sort of makes you tick as a professional?
Yeah, thank you, Andrew. So, I'm one of those people that knew they wanted to be a doctor early on. My 8th grade yearbook had sports medicine position as future occupation. And I didn't realize that until I got into med school and looked back at it. But my training, so I went to an osteopathic school, right? So I only applied to osteopathic schools, and the reason being is they appealed to me by the way they approach the patient, right? We do manipulation, so we put the hands on the patient, right? The body, they don't separate it into systems per se, right? The body is a unit is one of the mantras of osteopathic physicians. So everything has an effect on everything else within the body, right? You can't separate something out and just treat that. So it's a very holistic is a kind of a word that's thrown around, but it's a holistic approach to medicine as you look at the patient.
Yeah. I love that view. That it's. Yeah. I always like to say it's a comprehensive view, right? It
very much so. Very much so. Everything.
If you turn one knob, other things get affected, right?
Correct. Right. Yes. If you affect, if you treat something, or if you look at the disease process, it doesn't exist in a vacuum, right? It's playing a part of. It has a role and has an effect on other things. And if you look at the body as an organism, it has effects elsewhere. So that's what you just have to be mindful of. And then when you treat, you have to be mindful of treating not only what's going on and addressing what's going on, but looking at how that has affected other parts of the body, right? So there's a thing I keep in my mind when there's a patient comes in with multiple complaints. Chances are, if you're betting that all of those are related somehow. I think the key is to A, realizing that they're all related, and B, if you find the keystone, that's probably where you have to focus your treatment, not at, not the periphery, because then you start treating different things, and certain treatments have their own drawbacks. So if you can find the keystone and attack that, you'll find that the patient does better overall.
Yeah.
So I went to Lake Erie College of Osteopathic Medicine in Erie. I graduated 2005. I did my osteopathic internship. I then did a year of surgery. So it wasn't a conventional postgrad or postgraduate trail, but I didn't know if I wanted to be. I knew I wanted to do sports medicine. I didn't know if I wanted to be an orthopedic surgeon or in the primary care sports medicine realm. And but that year of surgery taught me so much. I think almost all physicians should do it as a part of their training, rather than just like the six week rotations. And then I did my family practice I did my surgical year at Mercy Hospital here in Pittsburgh. I did my family practice at West Penn Hospital here in Pittsburgh. And then I went to Erie, PA to do my sports medicine fellowship. And coming out of fellowship, I wanted to do sports medicine. I wanted to focus on musculoskeletal medicine. Yeah. And it's a new specialty, relatively speaking. The American Medical Society of Sports Medicine is only 25 years old, but it's grown exponentially over the last, say, 10 to 15 years. The downside of that was when I was coming out of fellowship, the ideal job wasn't there.
Didn't exist yet.
Yeah, right. There weren't enough of those positions for everyone to join into. Sometimes you end up as a family practice, right? So you join a family practice program as the sports medicine doc, but in all reality, you do 98% family medicine, and you see all the sprained ankles, right? That's really how that happens, and I didn't want that to happen. And then there were a couple spots I thought about taking, but I would have had to move my family to, I think one was in Lubbock, Texas, at Texas Tech.
Gotcha.
I mean, West Texas isn't exactly a destination. So
it's a bit barren, unfortunately.
Right. So with everything, I decided, let's try to start my own practice, create what I want, in essence. And it was a bit risky proposition, as you know. I mean, you started a practice and a business, so you know firsthand what that requires, all the work behind the scenes.
Absolutely.
But I started a sports medicine practice, and I was actually doing urgent care at the same time. So I've got that experience, right? The urgent care experience, which I don't know, it's medicine, but it's kind of triage, right? So I think they're overused a little bit, but that's another topic for another day. So I set my practice up. I had physical therapy. I put a physical therapist. Actually, I subcontracted my physical therapy out at that time. It was just a better business decision, and I opened up, hung out a shingle, and started getting patients and developing a reputation. Really, that I listened. I guess that was the big thing. Like, people say they weren't used to it, which shouldn't have surprised me, but I was just surprised how much people wanted that, I guess is the key.
Well, and you and I have talked about this before. I think it's why we align so well. It's,
right.
The traditional model of medicine that's created, right, is, doctors stagger appointments, 15-minute appointments in 5-minute staggers so that they can see 60 some people a day. And they're walking in, reading a chart, and they're looking at the key top pieces, and then they're hearing the chief complaint come out of the person's mouth, and then they're throwing something at it, which sets it up so that they're treating the ripples, not the stone, right? But also patients feel unheard. And at the end of the day, you and we chatted about this a little bit ago, right? Is you know, that model that the doctor was the smartest person in the town that you called for, you know, all advice, including your taxes,
Right.
is a dead model, right? Yes, doctors are intelligent people, but there's a lot of intelligent people, and we now have access to abundant information. So now people want to ask questions. They want to take ownership of their health, and that old dated model of here, do this, don't question me, just
Right.
doesn't work anymore. And so that's why I was so enamored by the practice that you've built, is because you are an example of a physician that recognizes how care needs to evolve. And it's hilarious because I even know within our practice, right? Our initial consult with dietitian services is a 90-minute consultation. So we sit down with our patients for 90 minutes, and they're floored at that, because we get to know who they are, what they're doing. We get to live a day in their life. We get to truly hear them. And to be honest, obviously I'm just a registered dietitian. So I have my RD. That, you know, was my undergrad, my residency for dietetics. And then I actually did a master's in sports medicine. So through the School of Sports Medicine at Pitt, in human performance was my master's. But it's to say that it's really sad to me, in the 7 years I've been in business, the amount of times I have caught a diagnosis that I'm suspicious of, that I have to then tell their doctor about. I mean, I've caught people. I met a guy that at 55 years old got diagnosed with heterozygous cystic fibrosis because he came into my office with pancreatitis. And I was like, you have mucus production. And I looked at his demographic and his background. I said, we need to get you tested for cystic fibrosis. And he came back positive. So after decades of being missed, he finally got an appropriate diagnosis. I mean, I had someone last week that he's a type 1 diabetic that's been getting treated as a type 2 diabetic. I mean, you name it. And it's sad to me how often that happens, but it's not that I'm brilliant. It's not that I know what I'm doing. It's that I listen, right? And I was really, I'm enamored by your model because of that. So I was going to say, maybe we segue that and you tell them a little bit about, obviously, as you built this practice, sort of the foundations that you built it on.
And that's the big thing, right? So my wife is a family nurse practitioner. She's actually been practicing longer than she was practicing as a nurse practitioner before I graduated med school, right? So her experience is almost double of mine, and she's fantastic. I would put her up against any PCP in the area.
Yeah.
And again, we knew the model was broken, right? You can't treat someone in 8 minutes. So after I started the sports medicine, and we kind of convinced ourselves it would work, we actually expanded the office size, and we started what is Epic Medical, and it's family practice. And honestly, our visits are 30. They're blocked for 30 minutes. Now, whether they take 30 minutes, so be it. There are some visits that just come in. Listen, doc, I have a sore throat, and there's a diagnosis, but our patients, so we base on that. And when you, as a business owner, you do the math and say, well, how many patients do I need to see to be able to keep the lights on and the doors open? Yeah. And while we're not saturated yet, we haven't reached this point, and hopefully we do. But the answer, once we get to a max capacity, the answer is not to decrease the time of the visits. The answer is to hire somebody else that can see the patients and spend that much time with them.
Exactly.
One of my teachers in residency said to me, they said, the patient, if you listen, the patient will tell you what's wrong with them in the first 5 to 8 minutes.
Yeah.
And there was another study that said doctors don't let the patients talk for more than 2 minutes.
Oh, wow.
Right. Yeah. Right. So if you take those two kind of thought processes, if you let the patient talk, they will tell you what's wrong. Like, it's almost the point where physical exam is actually the second most useful tool. Yeah. The first is them telling you, and asking questions, but letting them talk, right? How many times have you been in an office where, and I'm guilty of this occasionally, you ask a question, or the physician asks you a question, and as you're answering, they kind of, they don't let you finish the answer. Like, if you just ask and let them talk, they will normally tell you, or at least give you clues to what's going on. So that's our model is really, it shouldn't be rocket science. It's just more time for the patients.
Yeah.
And that helps us not have to be the reactive physician, meaning, oh, your blood pressure's up, here's your script for blood pressure medication.
Yeah.
Usually when that happens, the conversation is, what's your diet like? What's your exercise routine like, or regimen like? What's your family history, right? And it's a conversation. And I tell my patients, first time I meet them, every time, it's nothing we do here. I'm not going to be paternalistic. I am not going to be the principal of the school. I'm not going to say, here, you need to do this, unless, and I said, you'll know when I'm serious. If I say you need to do this, then you really need to do this, because your health or your life depends on it. But every medicine I give, every ounce of information I give, there's a conversation about. And they, bottom line is, they know the risks of not doing it. They know the benefits of doing it. They know the why I'm having them do it, and then they can make an educated decision.
Yeah, it allows them to feel informed and feels like they're actually taking part in their health, and that's got to be very empowering to your patients. And like you said, it's really sad that our medical model got so far removed from that we got that's not the norm, right? I mean, like you said, it's not that it's rocket science. It's a pretty core and proven concept that if you listen to people, they will tell you what ails them. And then based on their willingness to make changes and all of those things, you can develop care plans and interventions accordingly. And yes, there are people that have no motivation to change and just want to be given something that fixes it. But that is not the majority of people, honestly. Most people want to know, what can I do? And like you said, in an 8-minute session where the doctor heard 90 seconds worth of content and then used their medical bias to assume that the person wasn't going to make changes, instead of asking 1 or 2 questions to elucidate this person's motivation, they're just saying, okay, yep, here's your pill, have a good day. And then the patient's left going, wait, what's happening? And once again, as the dietitian, I'm the one that then the patient decides to come out and meet with me, whether because the doctor did say, oh, you could meet with a dietitian, or because they said, what can I do about this? And they start going online and reading, and they come across our website and they're saying, yeah, I started taking this medication because the doctor told me to. And I don't know if this is related, but I'm just sleepy and I'm achy and I'm sore. Right. And it's like, oh, are you on a statin? And they're like, yeah, I'm on simvastatin. It's like, well, did anybody talk to you about the fact that, well, yes, that is a cholesterol lowering medication. It does have side effects like making you physically achy and sore at times. And they're like, no one said anything about this. So now they were given something that they thought was with their best intentions in mind. They were not alerted of what were the expectations of it. And now their trust is completely breached. And we wonder why we live in this world where people are so anti-medication now. And to be clear, I think that is to the world's dismay, right? We've got to realize that our average lifespan went from 65 to 81 over the last 100 years, largely because of medicine.
Because of medicine, yes.
Yeah, like that. I mean, that 20-year improvement was largely because of medicine, because of vaccinations, because of antibiotics, because of cholesterol and blood pressure related medications. That said, we definitely can't be living in this world where we just prescribe them first. They need to be a part of that picture. And so it's always a pleasure to know a physician like you that actually believes that as well. And like you said, you're going to talk to them and say, as you get to know what's going on in their world, you're going to make that referral to the dietitian, and then also discuss with them the other pathways that can build on top of it. And now all of a sudden we have medicine coming, not in this biomedical model of patient presents with symptoms, you slap Band-Aid on symptoms, discharge patient, but instead we're giving them an opportunity to dig into what I've always been called by, which is that biopsychosocial model of care, right? Recognizing the genetic and biologic factors and the social factors and the psychological factors and how all of those are interacting. Is this person depressed and lonely? And if so, why are we surprised that they're emotionally eating? As an example. So we can build a care plan when we have a better picture of that person, but to have a picture of the person, you just need to allow enough time. And like you said, 30 minutes to really dig in is going to be massive, because you're going to be able to set them on a path forward. And then in a dietitian visit, we're going to spend even more time, but that's just because we're the ones that are distilling down the really teeny, the actual habits that are creating the avalanche, so to speak. And it creates outcomes in a way that most people are absolutely floored by.
And you would think it's amazing how many times I've had someone who I've said, if little changes, right? I can think of a patient who was drinking like 3, and I, the person about his health, and I said, if you stopped drinking Mountain Dew altogether and just substitute that with water, you would lose weight and you'd be less tired. Sure enough, he tried it. He did it, like almost like cold turkey, went off Mountain Dew, and he came back. He's like, wow, I'm surprised that worked. And that kind of baffled me. I'm like, why are you surprised? Because I've always said, I tell my patients, there's nothing good about soda. No offense to the soda drinkers, but
you're not wrong.
But it's just sometimes I guess that's one of the things you can't assume. Not that the patient doesn't know, but you can't assume that the patient understands some of the processes or the cause and effect and what the result would be.
Yeah.
We're trained in medicine, right? And sometimes we take it for granted. And I think that's one of the biggest downfalls is we only see things from our scientific or our investigative minds, where these patients, this kind of triggered that when this guy is like, I'm surprised that worked. I'm like, really? If you do 4 sodas, 4 20-ounce sodas a day, and you think that's healthy. But we have to keep that in mind, especially with, so to your point about, there's so much information out there, but we have to be discerning about it, right? There's a lot of bad information out there. So
yeah.
While sometimes it slows me down when patients come in and say, oh, I Googled my symptoms, and this is what I have. And I'm the first to ask the patient, hey, what do you think is wrong? Right. And sometimes, and I don't discredit any of their recommendations, because they're going to go home and Google their symptoms. And if they come up with something that maybe wasn't on my radar, because they're probably a little more honest with Google than they are with me, and they put their symptoms in and they mention something, I'm like, well, I don't know, but we can test for that, because that actually makes sense.
Yeah.
So I don't, there's good information, and that helps me a little bit. But especially like nutrition, right? When I tell people, medication, much like food, causes something to happen in your body. Causes some kind of biochemical reaction. So in essence, food can be looked at as a drug, and sometimes that's the approach I have to take with patients, where they're like, wow, you're right. If I eat a bowl of pasta, I feel blah. Well, that's the insulin. That's the same thing as this medication might do.
Yeah.
So I think not assuming, I guess that I should say, making sure, taking a second to ask the patient, do you understand what I'm saying? And making sure they repeat it back, and making sure you're on the same page is important, because I think that can get lost. It's too numerous to count the times where a patient has said, oh, the doctor said this, but I went home, they're coming from a specialist. And I said, what did the specialist say? Like, well, they said this. I'm like, well, what did they say about that? I'm like, well, I forget, or I don't know, or they tell me something different. And I look at the consult note, and then there's just this disconnect. So sometimes you have to put it in just a different language. It's a communications problem.
Absolutely. Yeah, and it's that need
right?
Yeah, absolutely.
Yeah. So, and to your point, to empower them to go to, if they're taking the initiative to A, come to me, and then B, taking my recommendation and say, listen, go talk to Andrew, go talk to a dietitian, and just get an idea of what you need to do to not only maybe fight an illness or fight a condition, but prevent a condition.
Yeah.
If they're that far down the road in commitment, then that's a good sign. Then they are usually heading for success in doing that.
Absolutely. And it's cool, because to a certain extent, going back to that comment I made earlier about how, our lifespans have elongated due to medicine. Right. To a certain extent, the thing we want to realize is that, like, we want to save the medications for as late in the game as we can, right? They're meant to be that kind of push to the finish line, if you will. And so when you have younger people, or, people that are being faced with medication the first time, it is worth asking, okay, is this something that we could intervene with using food as medicine, so to speak, or changing, lifestyle protocols, because that buys us that time, right? We know that once medications start, it's harder to get rid of them. And we get to a point where you need more and more and more of them, right? It starts a clock in a lot of ways, especially in chronic disease prevention.
Yeah,
more than
really
any
does.
other one. And
Yeah.
so we owe it to them to give them that knowledge. And I think that's probably one of the other disconnects, is because there's this fast medical model that's really quick to prescribe and not explain. We end up with people that either take those meds and don't, and they think that that it's fixed, that they no longer have to do anything, or they distrust those meds and they avoid them and rebel against them. And both of those outcomes are to the patient's disadvantage.
Yes.
That is not the optimal version of care. We want to have people that understand that medicine has its place and lifestyle intervention has its place, and they're meant to be combined in a way that allows realistic actions to take place that reduce risk and improve and maximize quality and quantity of life.
Yeah, definitely. And it's, I tell my patients, I know life exists outside the box of this office, right? Like, there are people that just may not have the time to exercise, but then that's when the conversation starts. Well, if you can't do this, then let's focus on this, right? There's always something they can do to improve. And I think that's where a lot of the time spent with the patient, that's where the conversation goes. It's kind of thinking outside the box. Like, anyone can write a script for exercise.
Yeah.
But don't tell the iron worker who's working 12-hour shifts and has a wife and kids, and don't tell them to spend 60 minutes on an elliptical machine a couple times. Like, that's not going to work. That's not realistic. You start thinking, well, I always call them, like, they're the industrial athletes, right? The people who have physically demanding jobs. So let's not worry about that. Let's worry about what you're consuming, right? Let's look at the diet part.
Especially on that shift work, we know that tends to be, and it's, the amount of clients I've had over the years, like, the mechanic or the shift worker that works in a big warehouse and gets 22,000 steps a day, and it's like, exercise isn't going to be the dominant prescription there. We're going to be looking at hydration status. We're going to be looking at meal times. Is the food filling enough? Because more often than not, their lunches are lacking, and as a result, they're just like not getting enough all day, and that leads to either afternoon snacking or obnoxiously large dinners, or evening snacking, or an excess combination of the three. And like you said, if you spend some time with a patient, you can more quickly see into their life. And like you said, yes, they come in with their concerns and preconceived notions of what's going on. But to your point, if you can avoid, excess anchoring and bias, you might be able to, as you said it well, I like the way you said it. It gives you clues. And that's really what we're looking for, is we can put together some clues to create a path forward that allows us not suddenly this like snap of the fingers perfect outcome, but a path forward that allows us to move in the right direction.
Right. Health and wellness is not it's not easy. I tell people this is not easy to do. The easy path is eating poorly, not exercising. That's the easy way to do it, right? If you don't want to do anything, but it takes effort. And I think in general, I've seen more people realizing, I think the generation before us, our generation and is looking back and saying, like, wow, some of this could to mid 30s, 40s.
You froze a little bit.
Ask about the family history.
Sorry.
I'm sorry.
Yeah, you froze a little bit. That's okay.
So what I was going to say is that our generation looks back at the previous generation, who the data they had, the knowledge they had about health wasn't quite there, right? As we grow as a society, we start learning more about what it means to be healthy, and that's why the longevity increases. And I think we look back and they say, well, my dad he developed diabetes, but he didn't eat very well. So that they look back and say, okay, this is what we have to do, and they realize they have to start earlier, and just take a generalized, a better approach, right? They may not be, hitting that, exercising 5 days a week, but they know that if they do a little bit, both on the exercise side and the dietary side and the mental health side, that down the road they will reap the benefits. So I looking back, that historical view helps me kind of convince them, like, hey, you don't want to do that. You don't want to have bad knees when you're 55. So weight loss may be important for you. I am seeing a lot more people who are taking an interest in their health. And it's got to be and it's not easy, but it's got to be, when you have a team helping you, right? So PCP, you have a dietitian, you have personal trainer, you have physical therapist, any of the health sciences. I think the team approach is much better, because you're right. Remember, like you said in your opening, the doctors aren't the smartest people. Like I know what I know because I've read and
you
I
studied like this. I mean,
right, exactly.
Yeah.
But I don't know what you know, right? So I'll take what I know, and then I'm going to send it to Andrew. He's gonna get granular on the diet and everything, and maybe think about some things that I don't know, like tricks I don't know.
Absolutely.
Right. So
yeah, I always laugh and say, I bill out through insurance as a medical specialist because I went to school for 7 years to help people with their relationship with food and habits. And so I am definitely more of that like psychological, behavioral, habit specialist. And so, yes, there's all those tips and tricks out there, but they're so blended and inundated with, Weight Watchers tips and Atkins tips. And this worked for this person one time, that my role is to help people navigate. And then from there, to your point, you even said it well, it's right. So you're having these conversations with your client, and you mentioned, with the way your knees are feeling, weight loss might relieve some pressure and feel a lot better. Go to a dietitian. Well, then the key there is to recognize that weight loss is a symptom, right? Like it is a side effect of habits that aren't supporting the person well. And so then we step back and go, okay, so then the dietitian sits down with them, and instead of us saying, okay, we need to lose weight, we say, no, let's take a deep dive at how you're living, and let's optimize your lifestyle. Let's look at how you're moving. Let's look at how you're fueling, and let's make sure you're doing things that are giving your body the right signals, just like a medicine signals to the body. Food, movement, stress management, sleep quality, hydration, all of these things are knobs that signal and tell the body things. And let's nudge those so that they create a different outcome. So now all of a sudden they've gone from saying, hey, my knees are sore and I'm becoming increasingly immobile, to, okay, if I drop 10 pounds, for example, my knees would feel less sore, to then, oh, I'm heavier because I'm eating a lot of inflammatory foods that are contributing to the ache. So it's now I'm going to focus on prepping more vegetables, increasing the amount of, quality within my dinners, reducing snacking by making meals more filling. And we've gone from a problem to actionable daily solutions, not just the vague advice of you need to do this or you need to do this, but no, let's live this way. Let's make adjustments to the lifestyle. And so we've taken basically a problem, invited a mission, and then developed goals. And like you said, it takes multiple practitioners to do that. You need to have multiple touches. But what's cool is when you make that referral, you make that encouragement, it allows those conversations to take place. So this patient comes out of this experience knowing the place for medications, knowing the place for lifestyle habits, and knowing some of the outcomes that will come from caring about all of the above.
Yeah, it really, they say it takes a village, right? And it really does. And there are people who come in, and I always tell, and I really do, I hate prescribing medicine, hate prescribing medication. Not because I'm big pharma, I would rather somebody come in and say, I have high blood pressure. What can I do to change it? That's what I try to bring that patient around to do. Now, does it always work? No. You have those patients who just say, listen, I know they'll tell me, and this is maybe building rapport with patients by spending time with them. They'll tell me, like, I'm not going to stop smoking. I'm not going to do this. And I say, okay, well, I'm going to treat you then with medicine, and they're on medication and they're okay with it. And that's, you're not going to convince everybody, right?
No.
But
you can definitely try.
Right? You have to. That's our job.
Yep. And I think that, what's cool is when we've said this a couple times in a few different ways, but when you think about it, we now live in this world where there's people that'll go, I refuse medication. Tell me what else to do. You have the people that go, I refuse life change. Give me the med.
Yep.
We have to realize that in that gray area, in that spectrum in between, I would much rather see a patient go on a low dose of hydrochlorothiazide as their only blood pressure intervention alongside increased cardiovascular activity, movement, mobility, alongside eating. Even like you said, even if food and movement and stress reductions can't get them exactly where they need to be, the combination of changing movement, changing food, changing stress outlets and habits, changing hydration, and then also using a medication, that's going to be the best outcome. It always goes back to when you do one thing to treat a problem, there's going to be issues with that, right? It's rare that we can just put one Band-Aid on. Ideally, we come at it from multiple angles. I like to give the analogy that basketball teams with one good player rarely win championships, right? Because that one person has to score all the points. And at the end of the day, I'd much rather have 3 players scoring 30 points each than one player scoring 50 points, and they're going to win every time, right? And so it's that idea of medication can be on the team, just like eating and hydration and movement can be on the team. But that's the point, is it's your care team, and we are simply the mediators of the care. We're the recommenders of the team. We're the scouts, so to speak, right? But we've got to assemble your care team and make sure that you're getting good, solid minutes from every person on that team.
Yeah, no, absolutely. And I do think most of the people are in that gray area. And there'll be people that come in and they have some hypertension, right? And their blood pressure is elevated, and unless it's really high, I never start medication first visit. And I say it's high. Let's bring you back. We talk about their diet. We talk about why it could be high, and say let's bring it back and see. We'll see in a couple of weeks and see if it's still elevated. If it's still elevated, and there's knobs per se we can turn, right, and say, okay, well, your salt intake's high, or your stress level's high, and something we can manipulate a little bit. I'll tell them, I'll say, listen, I'm going to put you on medication because I want your blood pressure a little lower than it is now.
Yeah.
My expectation is that we make the changes we talked about, we spent the most of the time talking about, and maybe we can take you off this medication. Maybe we can decrease the dose of this medication.
Yeah.
Because I think at the end of the day, and like you said, like there are some people you could do everything right, and you have essential hypertension, you have familial hypercholesterolemia, right? Those need treatment, and that's where medication has helped increase the longevity and help the prevent a lot of unnecessary comorbidities and death going forward. But at the end of the day, it's always better, and I think people will feel better if they can control what I'm going to say this, like if they make the habit changes and the lifestyle changes that will positively affect some of these conditions. I think they'll be better off, kind of like you said, we save the medication for not the end of life, but down the road, right?
Yeah.
The golden years, if you want to say that. But like, let's not start now. Let's not give up on being able to manipulate this now with dietary changes, because they're looking at it holistically. Chances are whatever they're doing that may be affecting their blood pressure is probably affecting something else too, right? If it's lack of exercise. So not only does the blood pressure come down, but they're just better off, right? Humans are not meant to be sedentary. So now we've got somebody exercise, and now their cardiovascular health improves, and their blood pressure improves. So you've actually improved the condition of the overall being just by addressing one thing. And if you would have said that to the patient previous, like, hey, we're going to fix all this, overwhelming, can't do that. But if you approach it from a very simplistic and very basic way, say, we just need you to move more. Okay, well, what can we do? And then that's when you break it down and say, well, that's where the conversation starts. What can you do? What opportunity? What's your daily life? And where can we fit it in during a week?
Yeah. Where are those incremental steps to change?
Yeah.
Like
just little things, right?
Yeah.
I think it takes 7 weeks to form a habit. So I always say, like, all right, let's work on this first. And in 2 months, come back and we'll see where we are. And then maybe you adjust it, maybe you change, maybe you add one. Because once you get that person on that, most patients on that positive reinforcement loop, they'll come back sooner and like, hey, listen, I feel good. What else can I do? What other changes can I make? Who
get excited to add to it, right?
Absolutely.
It's funny because just like a vicious cycle, right, of stress impairing sleeps, lack of sleep impairing mood, a lack of mood impairing and creating that vicious cycle. Positive habits create a prolific cycle, right?
Yes.
You move more, sleep better. You sleep better. You want to eat, you feel more alert. You have a better mood. You don't get as drained. You don't get as drained. You don't emotionally eat. You don't emotionally eat, right? It's like, it's that prolific cycle is absolutely possible, but you said it well. You got to start with one thing. It's got to be something that starts that cycle and lets it build. And yes, it takes time and it takes patience, but man, is it valuable. And
Right.
you have people like you and fighting in their corner and encouraging them and saying, hey, let's give this 2 months. I think sometimes that's the kind of information that's really helpful, because it's not the traditional model of here's a pill, see you in 2 months to see if it did what it's supposed to. It's no, we can hear that these things need to adjust. Go check out case specific, let's put you on this. Let's do this. Let's play around with this. Let's get you moving. And then in 8 weeks, let's see how you're feeling. And now all of a sudden we've planted some seeds that they can now work, and they have realistic expectations of, okay, over the next 8 weeks, this should gradually get better and better and better. And so you're giving them this, it's not a quick fix. It's not an immediate, you're pacing them a little bit, which is very, and it's going to allow them to feel like they're on the right track and they're not like letting everybody down or letting themselves down. So
right.
This is wonderful stuff. So I think the biggest thing is, will you just run through, within your practice, I guess the big comment of, if someone wanted to work with you guys, I guess it sounds like you guys really do see most patient types. So kind of give the rundown there, and then let us know how people can get a hold of you. What's the best way to contact and, become a part of the Epic Medical, consideration?
Sure. Thank you. Yeah. So, we're actually multi-specialty, right? So I have a family practice, and myself and my wife, Christine, and I do sports medicine. Okay. So we have those, and we have physical therapy on site, and we actually just added on site, and this is a little off. So it's Botox, fillers, all that stuff. But
Gotcha.
So yeah, so as far as the what's that?
I said no. I said that's wonderful. No, that's really cool.
So as far as becoming a medical patient, we see everyone. Family practice, pretty much birth to death. We don't. We start with ages 5 and up. So we don't see babies, don't see newborns, only because of the vaccinations. I mean, I think the pediatricians are better off, are better equipped to see that group of people. But 5 and up, we are in network with pretty much every insurance plan. There are 2 UPMC products that are bought off the ACA that because we're an independent practice, so we're not owned by UPMC. So those plans only have, I believe, employed UPMC doctors. Yeah. But other than that, we're pretty much accepted across the board.
Cool. Random side note: did you see Highmark's has a version of their plan this year that just came out that's that way?
That it's only AHN positions.
Yeah, we just had our first one. I don't remember the prefix, but we're in the same boat as you. We're private practice. We're a network with everybody, but there's always been those couple UPMCs that are only if it's UPMC facility. There's now a Highmark plan that does that, and it's AHN only. Just a random side note, just to give you a heads up.
I did see the name of because I'm familiar with the Highmark plans, and I did see one that I didn't recognize before. So that might be it. I'll have to check on that.
But sorry to interrupt you, but yeah, so you guys are in network, and you play well in the sandbox with all the insurances you can, which is a great thing.
Right. Yeah, you have to. And I mean, insurance is a real thing, and people wouldn't be able to afford healthcare if they didn't have it.
Yeah.
And actually, I'm going to spin back to that in a second. But so I guess the best place to find the contact information with going to the website is Epic Medical PGH. So in essence, epicmedicalpittsburgh.com. And I will admit we haven't added completely. Our therapist just came back from maternity leave. Just had a beautiful baby girl. So we haven't expanded the therapy part of the webpage. But that's all the information you need. We're located. We're in Indiana Township. We're kind of at the crossroads of Indiana Township, Fox Chapel, and just outside of O'Hara Township. So while all these roads in this area wind around, it's really not a far drive from 910, Route 28, coming down from the north, Route 8. So it's really not that hard to get to. We're a fairly busy intersection. we see, it's family practice, right? So we see everything. And I see, sports injuries, right? So just, you don't have to be a member of the family practice for me to see you for musculoskeletal injuries, or overuse injuries, or the asthmatic athlete, the diabetic athlete, the concussions is actually, concussions is one of my specialties.
Okay.
And I will say, so going back to the insurance part, you may see on the website, or you will see on the website, I also have a separate part of the practice I use the term concierge medicine. Some people will use direct primary care, and what that is I don't use your insurance. It's almost like a membership.
Yeah.
And it's 24-hour access to me, whether it's email, cell phone, text, and we don't charge per office visit. I really don't run their insurance for anything. And we can expand on that some other time, but it's interesting that the types of patients, it wasn't the type of patients that I thought would fall into that. It was types of patients who felt like their doctor wasn't giving them enough time, maybe with a complex medical disease, and then they need somebody to quarterback all the specialists. So it's a commitment, right? It's a financial investment in your health. So that's slowly growing.
And that's also getting a lot more popular. I mean, that idea of,
it is, hey,
pay this flat rate monthly and it gives you access to care when you need it, period, end of story, no questions asked, kind of thing. That is, and it's in part because while insurance right now is necessary, it's largely necessary because of how overpriced things like testing is.
You have no idea.
It's.
You do have an idea, yes.
But
right.
people don't realize, but unless they've received some of those medical bills or EOBs and actually looked at some of the itemized. But it's to say that, you get to a point where it's like insurance has to exist to save that, but it also goes back to a certain extent, insurance for a lot of the population. I mean, for example, for me, I pay an exorbitant amount for my health insurance, and it does very little for me because I don't utilize it. And so it's there is that sort of flat rate fee model of, hey, if I needed access, this gives me what I need. So I'm happy to hear that you have that available, and it gives patients that next level of care and that one-on-one, where instead of just, calling the doctor when they need and maybe only getting with the NP or the PA or one of the other doctors, and not that there's anything wrong with any of those things, but the traditional model creates a very disconnected care. And so having someone that gets you and has access to you specifically, them, you're going to build a better relationship. And just like listening once for 30 minutes gives you insights, listening to someone for 30 minutes 4 times a year over the course of 3 years, you're going to have a pretty good idea of who they are and how their life is evolving. And you're going to be able to make better recommendations, not just as a trained medical specialist, but as someone who's kind of trained in that person.
Well, right. I can't treat you unless I know you, right? I can't. I can treat numbers, I can treat labs, I can treat images, but I always tell people I don't, so musculoskeletal medicine, they're like, oh, my x-ray, this is what my x-ray looks like. I'm like, well, I don't treat x-rays. X-rays can look, you can have findings on the x-rays that don't correlate to the clinical symptoms. So I need, I don't treat lab values. I don't treat, I treat patients, right? And that's bottom line.
I love that. Wonderful. Again, I think what we're going to do is we're going to cap it here. I know that you and I have other things that we could delve into together, and I know that we will pick a time and a place to do just that. But at base, again, epicmedicalpgh.com.
Yes.
Again, Dr. Skavarla, Eric, as I know him, and his wife.
I was Eric before I was doctor. So.
There we go. Him and his wife have an amazing practice. They've got a great team. They're comprehensive in the world of physical, sports medicine, as well as family practice. And again, a really, really great resource here in the Pittsburgh area. A great professional collaboration with my group, Case Specific. And I want to just thank you again, Eric, for coming on today and talking and kind of helping people maybe better understand that gray area that is where medicine and preventive wellness do coexist. Not that they can, but that they should, and they do if you let it. So thank you for your time.
I appreciate the opportunity. I do want to say, so this kind of came out from the case specific meal prep, and I do want to give you the meals are fantastic. I keep them
Thank you.
here in my office. My son's very active. They're quick meals for him. When everything's hectic, when he's going from soccer to track. For me in my office, I spend so much. Vince does a great job. I don't know who else is behind the scenes there, but the quality, the portions, the pricing is fantastic. And I know I've had some patients here. I've gotten quite large orders that come delivered here so they can pick them up. And I was like, I don't have enough room in my fridge for these. So
you gotta get you a bigger fridge.
Yeah, no, I got. I'm gonna look like Giant Eagle soon.
Exactly, I love it.
But I give you guys a lot of credit. But well done with the meal prep. And I hope, because that may be the first step into people like, hey, you know what? Maybe this isn't all about eating kale. Like this is it's real food, and they feel full. And like who did this, and that's when it makes it a little easier, a little more. They need a little less convincing for me to come see you.
Beautiful. No, I'm happy to hear that. Thank you for the plug with the CSNP. Yeah. We've been really proud of it. Vince and I have been building this for over a couple of years, and it obviously this past year has been great. And the team involved has really come together nicely with our chef Isaac, who's fantastic, and we have a second chef and a team of assemblers and deliverers, and it's kind of taken on a life of its own as it's supposed to. But there's something about those high quality meals that a dietitian helped create to create consistency and nutritional validity, and then a chef took their spin on and made delicious. Right? It's
the sauces are exceptional.
Good.
I know you can buy them. You can buy the sauces separately on the website.
On the website. Yep, absolutely. So I'll do another shameless plug for everyone listening. That's our new internal case specific meal prep, csmpgh.com. I'll end up linking epicmedicalpgh.com, csmpgh.com in the show notes. But in the meantime, thanks again, Eric. Thanks everybody for listening. Don't forget to share this episode, tag a friend, tag a loved one, #spread the health. Eric will be back for another episode. Him and I are going to dig into some fun stuff together. But in the meantime, be well, and we will be back next week with another CSN3M Mindset Monday.
Awesome. Thanks, Andy.